The entire healthcare policy journey in this country for a number of years now has been a gradual descent into a kind of madness. And we've been trying to track it to the best of our ability. But here to help us perhaps make a little sense of that is Timothy Faust. Tim is the Chapo Trap House healthcare correspondent. He is also pursuing an MPA, that's Master's Public Administration, in Health Policy and Finance at NYU. Tim, first of all, thanks for coming on the program.
Oh, howdy, y'all. Glad to be here.
And I also asked you just before we went on the air whether you were the same Timothy Faust who wrote for Vice, "I Play the Boys Are Back in Town" on a bar jukebox until I got kicked out, and you answered in the affirmative.
That's correct. It's my life's work.
Well, you know, God bless you for it, son, except for the fact that I do have a long-standing grudge against Thin Lizzy having to do with a girl I dated in high school who ran off with one of the band members. But
Yeah.
Any advice for me? I mean, I think I'm over it now, but any advice for my broken heart?
I mean, I just hope that maybe through exposure therapy, you can learn to love the song again, which is really all I was trying to do, was to help people really dig deep into exploring the best song on Thin Lizzy's Jailbreak.
And how did that work out for you?
I had a good time.
Okay, there you go. All right, now on to healthcare, where, okay, I know my opinions on this. I would say the audience for this program has probably a good idea of my opinions. What do you think of the current state of the healthcare debate? And by that, I mean what the Republicans are trying to do and also the Democratic counterpositioning.
Well, the more pressing one in the news is the GOP position, right? You've got both the AHCA and the BCRA. It looks like the BCRA is dead. I know a second version was CBO scored, and I'm glad. I'm glad it appears to have totally stopped. You've also got the repeal entirely bill, which it looks like won't go anywhere, which is extremely good, unilaterally good. On the other side, you've got the Democrats who don't quite seem to know what they want to do. A big reason for the ACA repeal bill was the idea that, if we don't repeal the ACA, the Dems will push for a single-payer program. And the Dems kind of took that and dropped it and went, wow, let's not be too hasty. You've got a party that has not really decided whether it wants to maintain the status quo of the ACA, expand the ACA, or push for a broader single-payer or universal healthcare program.
Well, what I'm seeing, I think that's right, but what I'm seeing in a lot of Democratic circles, at least here in D.C., is a kind of papering over of those fault lines in the Democratic position, where people are just basically saying as a default, we want to protect the ACA, and then when we're back in power, we'll make it better. And I'm trying to figure out how that translates in political terms, but also how it might translate in policy terms. First of all, the political, do you think that's a compelling argument? Do you think that's a strong enough position? What would you do if you were dictating health, now in this case, political rhetoric for Democrats?
No, geez, I mean, I think it's one of the least morally ambitious positions one can take. 28 million people still don't have access to insurance in the U.S. Now, granted, the ACA did a lot to drive that number down from 50 million, but that's still 28 million people. Premiums in the ACA this year went up 22%. Now, it's for a lot of reasons, having to do with the executive office not subsidizing insurers the way that they promised they would. But no, the ACA is already great, is not compelling policy. I think right now is the time to push for and demand a universal single payer or universal healthcare plan. I mean, like radicals like the Harvard Business Review are beginning to publish articles about the inevitability of single payer. I think that came out a couple days ago. The Democrats, Obama pushed out the ACA, right? And then really failed to champion it, I think, on the national level. That's why there are a bunch of problems with enrollment in 2013, 2014. Why it was a big concern. It took Paul Ryan, kind of perversely, to really make the case for the ACA to the American people by trying to cut it and by trying to cut Medicaid. entitlement programs in healthcare are sticky. Once people have them, they don't want to lose them. And it was only when this program was under like a credible attack, as opposed to just like years of obstructionism, kind of as a rhetorical device, that people began to realize, oh, like having healthcare for the first time, even if it's not very good, like is very nice. This is a nice thing to have now. I don't want to give it up. And so it seems like the natural next step is to demand, okay, well, we're going to take this thing, and if it was a piece of incremental legislation, it's time to take it to the full throttle. It's time to really push for a federal single payer. That's what I would do. People are compelled by that. I think right now, for the first time, a majority of people are, if you ask them, do you want a federal single payer, will say yes. That number changes around a little bit depending on how you phrase it, but like there's this big mass, this big bulwark of people in America that want this thing and know that they want this thing, and they're just begging to be catered to. It's a big pile of voters that are waiting to be picked up by whatever politician or party just has to be the most ambitious in going for it.
Yeah, I'll add one number to the numbers you listed, and that is 11,000. I think it's $365. Milliman, the actuarial firm that when I was working in healthcare, they were the leading firm, all the health insurance companies use them, says that the average family of four with quote unquote good employer in health insurance, that's how much they pay out of pocket for health care every year when you count premiums, co-payments, deductibles, things that aren't covered, and so on. More than $11,000 a year for a family of four. That, to me, I don't know what you think, but I think that's an unsustainable number. I don't think that the American, to the extent that there is any kind of middle class left in this country, put it this way, I don't think that working people in America can afford that kind of cost.
No, absolutely not. That kind of low actuarial value plan pushes more costs on individual people, which we call consumers, which is just a libertarian translation. Over the past 40 years, you've seen more and more costs shifted onto people. More co-pays, more cost sharing, more co-insurance, higher deductibles. And then but costs haven't gone down. Medical costs increase faster than inflation every single year because no party in our healthcare system has the leverage or the size to really be a exert downward pressure on costs. And so we just push more and more of the costs onto individual people, and you see that reflected in premium increases and deductible increases. And at the end of the day, they're getting squeezed, costs aren't dropping, and fewer people can afford coverage. There was an experiment in the 70s, the RAND health insurance experiment, which looked at the impact of pushing costs onto people by introducing co-insurance, co-pays, deductibles, that kind of thing. What we found is that people don't stop seeking emergency care, right? People still go to the ER if they get hit by a car or get rabies or whatever. They stop seeking preventative primary care. So we have a system in which people are disincentivized to get the low margin, high volume care like vaccinations, checkups, like cancer screenings early on, that long-term saves a bunch of money, and thus spend all that because they're afraid of incurring those costs and can't afford it. And then we see them pop up in the hospital when things are too late. It's absurd. It's a broken system.
Yeah, and there's a lot of evidence too. I mean, there was a misinterpretation of the RAND study that was very popular in the 80s and 90s that said that, well, people will avoid the care they don't need, but they'll still get the care they need. That's been, as far as I know, utterly disproven, right? I mean, people just don't get the care they need. And if
people don't get preventative or primary care and wait until like they've been smushed between two semi-trucks before they go to the hospital.
Right, and if you look at the OEC data, and that's the data from basically the developed countries around the world, and you compare Americans are always an outlier when it comes to questions like, did you fail to get medical care you needed in the last year because of the expense? That kind of question. We are always bringing up the rear. So we have a broken system. I think we agree on that. What about the kind of cost model? I mean, I went back recently, I'm kind of compiling an anthology of stuff I'm doing and of stuff I've written. I went back and looked. In 2007, this debate was going on about how much should people have to pay for health insurance, and I made the point, well, we already have a system for working that out. It's called progressive taxation, where if you have more, you pay more. If you have less, you pay less. How long can we continue a system where people are expected to pay premiums to private sector insurance companies that don't have an incentive to control costs, and then maybe the federal government will pick up a portion of the premiums. How sustainable is that model in the long term?
I think we're going to find that the Trump administration and HHS under Price are going to enable kind of a bizarre form of accelerationism on that question, right? They've already telegraphed that they're going to try to cut cost sharing reductions. They're going to try to cost a lot of the kinds of subsidies that the federal government gives to private insurers, which in return is reflected as premium increases. But fundamentally, you're right. Like, if we just keep pushing these costs on people that need healthcare, at some point it'll break. There's going to be a break somewhere at some point in time. I think the specter on the horizon is home health aides and aging boomers, right? Like, if our options are either like home health aides, I think there's going to be 1.2 million in 2020, and their bill, I think, now at $135 per visit. As the older population, like, we want to keep as many older people out of the hospitals as much as possible, right? If we don't have a way to push costs down, we don't have a way to create that preventive primary care and create access to it before people are on Medicare, you're going to see a bunch of people later in life spiking up costs. So I don't know where it stops. Surprised it didn't stop a while ago, but cost regulation and coverage expansion are two things that we need to demand immediately.
Okay, good answer. And here's a question I won't ask you, and then one I will. I won't ask you what kind of system you would design if you could wave a wand, because you are clearly a rational human being, and so you would design a single-payer system, obviously.
Right.
But, so let me ask you this question instead. What if you were czar of American healthcare right now? How would you get us to single payer? How would you get us to Medicare for all? Given that there's, we overpay specialists, we have misallocation of physician resources because the financial incentive is to become a neurosurgeon or cardiac surgeon or whatever, not to become a primary care physician who we really need. So I guess my question to you is, obviously it would probably take 14 hours to answer, to give justice to the question, but just a brief, how would you get us to a common sense system?
Cool. Well, I have two opinions on that. One is non-reformist reform, which is working outside structures that exist and thinking of what could be. And that would be just a blanket federal reformist reform, working with things we currently have now. I think the answer begins with Medicare expansion to people under age 26 to bring down per person costs in Medicare, dramatically inflate the number of people that are enrolled in Medicare, and finally disentangle a parent's employer status from whether or not a child has access to healthcare, and also reduce a lot of the pressure people have to get employed to get healthcare. That's step one. I think step two is using this larger and per person cheaper Medicare to begin doing the real work of cost negotiation, pushing costs down. One, you got to get the AMA out of the DRG, and the AMA has a privileged position which they get to argue for how their own prices should be set. The AMA disproportionately favors specialists because they disproportionately make up members of the committee that change the rules of the update committee. And so you have this crooked circle in which specialists argue for higher payments for specialists' care, which one, disincentivizes primary care providers from seeking that course of employment, and two, pushes costs across the entire spectrum all the way up, since all costs are set as a function of Medicare costs. So you need Medicare reform, but not in the sense of reducing spend, of finding new ways to allocate it, right? Like, I think that our overall level of spending in America is probably fine. We just allocate it really, really, really poorly. Right now, I think, $200 billion of fraudulent Medicare Advantage subsidies were given out in the past 10 years. Like, we have all this money we could be using on things like housing is healthcare, or food is healthcare, or the actual good work of social determinants of healthcare, but we spend it on subsidizing the wrong people to do the wrong kind of work at the wrong times. So expand Medicare, use it to push costs down, expand the role of Medicaid. Medicaid, I think, is one of the unsung heroes in global health. They do so much with so little. Give them the budgets they actually need and let them build out localized models of health. I don't know if a NHS type system would work necessarily in the US because we're a very heterogeneous population. Healthcare needs in urban New York and rural Kentucky and Seattle are all different. But Medicaid's already doing that work of finding out what works in different areas. Let them adopt this expanded role of Medicare's cost reductions and give them the budgets they need to actually explore how do you build healthcare people need in the places where they are. Number 4, you could either build a public option or just begin consolidating these things and expand Medicare to all people. I think both have their merits and both would have people pushing against it. Public option is easier to pass a little bit because you can change corporate incentives to remove the employer mandate and then replace it with a tax that goes to fund the public option. So people transfer where their money goes into a public system instead of a private one. But a public option could be throttled pretty easily by private interests, kind of like what you see with Stafford loans in education, right? Like the private interests will attempt to make public option less effective. The other alternative is just expanding Medicaid fully, or Medicare fully, which I think is really what we want to get to. Now, I don't mean Medicare the way it is now. Right now, Medicare has 20% co-insurance and no out-of-pocket limit. I think you want a better version of Medicare that has first dollar coverage for all Americans, which means that the cost of health treatments are paid for by the federal payer. But I think that it's a good model, a good structure, and makes sense to people when you want to advocate for something. And then finally, when this thing exists, like single payer isn't the actual question. Single payer is just the first step to addressing the actual question of what do you do as a government to make people healthier, right? If you realize that a large portion of your population same with food. People will have access to healthy food or food that's nutritious and near them and cheap in price. Then providing healthy, affordable food is a form of healthcare. That's the actual work. That's some of the stuff that Medicaid does. I think really well. That's what we actually want to get to. Single payer is just the first step in actually tackling what it means to have a healthy population and a healthy nation.
And I think that's a great list to which I would only add 3 items, and then we'll have to wrap up at item number 1, eliminate all drug patents.
Oh, absolutely, yep.
Item number 2, free medical school. Item number, tuition-free medical school, anyway. Item number 3, an aggressive environmental program so that adding to your list of preventive health care, we aren't poisoning the air and water people breathe at the same time that we're spending money to make them well. So, but I think that's a great list, Timothy Faust. So thanks for giving us that. Thanks for coming on the show, Timothy Faust, healthcare correspondent for El Chapo Trap House, and dare I say Thin Lizzy fanboy as well.
Yeah, it's a wonderful album. I love Thin Lizzy.
And they're pretty good. And thanks for coming on the show.
Thank you so much. This is fun.
Yeah, absolutely. And I am Richard RJ Eskow, and this is The Zero Hour.